All right. Hello and welcome to Noon Conferences hosted by MRI Online. In response to the changes happening around the world right now and the shutting down of in person events, we have decided to provide free daily noon conferences to all radiologists worldwide. Today, we are joined by Dr. Scott Steenburg. Dr. Steenburg is an associate professor of radiology and a trauma and emergency radiologist at Indiana University School of Medicine in Indianapolis. He has participated in over 100 invited lectures, and his primary research interest is CT of multi-system trauma. A reminder that there will be a Q&A session at the end of this lecture, so please use the Q&A feature to ask your questions and we will get to as many as we can before time is up. That being said, thank you all for joining us today. Dr. Steenberg, I'll let you take it from here.
Thank you very much, and it's an honor and pleasure to be here with you today. I'm looking at the attendee list, and I'm recognizing some names of people who I know who live on the opposite side of the planet from me, so I think this is amazing. So thank you for the opportunity. So today I'd like to talk to you about imaging of peripheral vascular injuries with special attention to CTA of peripheral vascular injuries. Um, I have one disclosure, but it's unrelated to the content of this talk. And of course, everything in this talk has been anonymized. So a little background about us here at Indiana University. Our ER division started about 14 years ago, and at that time it was 5 faculty covering 1 hospital, 24/7, 365. At that time it was modestly busy, 100,000 ER evaluations per year, about 3,000 trauma patients per year, of which about a quarter were the most severely injured. Fast forward to current state, we're going to have 26 ER radiologists, including 6 neuroradiologists. We cover 18 hospitals from around the state, including 3 level 1 trauma centers, 2 adult and 1 pediatric center. And we have approximately 8,000 trauma activations per year. And our ER division is pretty busy. I think we're on target to exceed 270,000 examinations this year. And our health system, our PAC system, is connected to over 100 hospitals throughout the state. So if you look at a map of our state, everywhere you see an IU branded symbol is a hospital where we interpret for. So we see a lot of work. So here are our session objectives. First, hopefully at the end of this talk, you'll appreciate what CTA can do for you in evaluation of patients with suspected vascular injuries. We're going to briefly talk about imaging protocols. Hopefully you'll be able to take that and then institute at your institution. And then we're going to go through a whole bunch of imaging cases to show you what these vascular injuries look like. So how were patients' peripheral vasculature evaluated over time? If in the 1950s or before, really it was nothing, do some damage control, or more often than not, amputation, such as this patient from the American Civil War with bilateral above knee amputations, presumably due to a large amount of soft tissue and osseous injury from some of the bullets that were used at that time. In the 1950s to 1970s, surgical exploration was the mainstay, primarily through the experience with military surgeons in the Vietnam War. 1970s through 2000s, it was really catheter angiography that was used to evaluate these patients with suspected vascular injuries. Now, this patient was the first catheter angiogram for peripheral vascular disease, but it was still a mainstay of diagnosis and treatment. And then current state, CT angiography is what we typically use to evaluate patients with suspected peripheral vascular injuries. A vast majority of peripheral vascular injuries are seen in civilian trauma centers, but as you can see, about 25% are seen in military hospitals. Most of these injuries will include the lower extremities, usually the femoral or popliteal artery, and usually in setting of penetrating trauma most often from gunshot wounds, at least in the United States. So what can happen? Obviously, you can have fatal exsanguination. You can develop multi-organ failure and systemic inflammation from hemorrhagic shock. Obviously, limb loss is a possibility, which can happen acutely in the setting of blunt trauma, primarily due to soft tissue injury, but it can also happen in a delayed fashion even after vascular repair. It should be noted that the amputation rate for blunt trauma is far more likely to be seen in blunt trauma primarily due to extensive soft tissue injury. Amputation rate following penetrating trauma is not that common. So here are the clinical findings of peripheral vascular injuries. We have hard signs and then soft signs. The hard signs include loss of pulses, an expanding hematoma, a thrill or bruit, and then pulsatile bleeding. Then the cold signs include a cool limb, non-expanding hematoma, a change of color of the extremity, and non-pulsatile bleeding. Patients with hard signs, over 90% of them will have a vascular injury. However, up to a quarter of patients with soft signs can have a vascular injury. So you can't exclude a vascular injury in the absence of a hard sign. So when do we image patients with possible peripheral vascular injury? Well, the literature is pretty clear. The Eastern Society for Surgery and Trauma in the United States says that CTA can be used as the primary diagnostic imaging study of choice in patients who don't need immediate surgery. For blunt trauma, it's a little more nebulous. The literature says that vascular injuries in blunt trauma is less than 1%, and I put a little asterisk here, which we'll talk about later. However, there are certain fracture patterns that are more likely to be associated with vascular injuries, such as open fractures, segmental fractures of the same bone, and then specifically knee dislocation. So any trainees who are listening, if you have a knee dislocation, you have to assume that there's a popliteal artery injury until proven otherwise. Little word about our own experience here at Indiana University, and this is pretty new data that we just published. We evaluated patients who received whole body CT, including lower extremity CTA for multi-system trauma. Our initial cohort, just after instituting this protocol, a majority of these patients did have lower extremity fractures, but nearly 6% had lower extremity vascular injuries. We were not expecting this high of incidence. And of those, nearly half had significant long-term complications, most commonly limb amputation. And also, we found that in our records, physical exam alone was insufficient to diagnose over half of these vascular injuries. So it's possible that there could be a subset of patients with subclinical vascular injuries that are associated with poor outcomes. So what imaging modalities do we have at our disposal? Obviously, we have digital subtraction angiography, Doppler ultrasound, MRA, and of course, CTA. So we're going to spend most of the time talking about CTA. But first, DSA. Let's talk about this. DSA remains the reference standard for patients with traumatic arterial injuries. The primary advantages are being able to visualize vessels that may be obscured by overlying artifact, especially bullet fragments, as well as being able to intervene and treat vascular injuries at point of care. Of course, the disadvantages are the increased cost, potential delay in diagnosis depending on whether or not your angiography team is in-house, and of course, catheter angiography can have complications though they're low. So an accurate alternative that's quicker and easier to do is desired. Doppler ultrasound, useful adjunct, but not really used widely in the trauma setting. Any of you who have done an ultrasound know that you can only evaluate what you can see with a probe, and it is highly operator dependent. Ultrasound looks easy, but it is not. Ultrasound also has decreased sensitivity and accuracy compared to angiography. And then you can only evaluate what you can see. And sometimes that's difficult with trauma patients who may have cast material, bandage material, external fixator devices, and whatnot. MRA has been used for a long time for evaluating peripheral vascular disease, and it performs actually quite well. But for many reasons, we just don't do MR in the acute diagnostic setting for a number of reasons. Usually an MR is not in the trauma center. Metal artifact, metal may preclude safely performing an MRA. So again, we want something that's quick and accurate and convenient. Which leads us to CT angiography. Most hospitals now will have a CT scanner that is capable of CT angiography of the extremities. It's quick, it's convenient, it's reliable, it's non-invasive, it's available 24/7, 365. It's easy to integrate as a part of the imaging workup of your patient, either as a standalone test or integrated as part of a whole body CT for trauma. It's highly sensitive and specific compared to DSA. And the other added benefit is that you can see all the other structures, not just the vessels, you can see the bones and the soft tissues. So potentially CT angiography is a one-stop shop for peripheral vascular injuries. So how does CTA perform compared to DSA? This is a busy slide. I'm not going to go through it all. I just want to draw your attention to the sensitivities and specificities compared to DSA. So CTA performs well. And if you look at the dates, these are some older studies using older technology. Let's look at a paper published by the Boston University group with their experience with CTA for penetrating extremity injuries. This is a retrospective study, 446 patients with penetrating extremity trauma. And in their series, nearly 1/3 of patients had a major vascular injury on CTA. So in the setting of penetrating trauma to the extremities, there's high likelihood of a vascular injury. None of the patients without a vascular injury on CT developed a vascular injury or needed vascular intervention. And they found that CTA was very accurate, sensitive, with a high negative predictive value, so you can rule out vascular injury. And it's helpful in characterizing the arterial injury type. So when do we do CTA? I find it helpful to rule out a vascular injury, especially if there's low or intermediate suspicion for vascular injury. It's helpful to rule in a vascular injury when the surgeon knows there must be a vascular injury, but we need to see what it is before we do any intervention. And what do you need? You need a multi-detector CT, acquiring the thinnest sections possible. You need a power injectable peripheral vascular catheter with a high contrast rate. You have to acquire the images during the systemic arterial phase, and there are lots of ways to do that, which we'll talk about soon in a little bit. And then you need to reconstruct the images in 3 planes, preferably 2mm slice thickness, but I've found that coronal MIPS are extremely helpful in evaluating the extremity vasculature. As you can imagine, scrolling through 1,000 or more 2mm slice thickness images can take a lot of time, but I've found that coronal MIPS give you a really good roadmap of what's really going on in only a couple dozen images. One pitfall is that small vessel injuries may evade detection using coronal MIPS, so you still need to go look at those source images, those thin slice images, to make sure there are not vascular injuries. And I found that sometimes a vascular injury morphology is best displayed in a non-traditional plane. So if you have access to a 3D viewer, that can be helpful. I strongly urge you to communicate with your surgeons about this. The ordering teams, they need to know what your capabilities are, and they may not know your capabilities. So you can avoid potential delay in diagnosis, excess contrast administration, if you just communicate with the team the team may not know that you can integrate extremity CTA as part of your whole body CT for trauma. So a lot of pre-planning, pre-scan planning and patient positioning and a thought that goes into this can help avoid some embarrassment and miscommunication. So there are lots of ways to do extremity CTA listed here. The lines with the asterisk are what we do at IU. We inject between 100 and 130 mLs of contrast, 130 if it's whole body CT, 100 if it's just an isolated extremity. One pitfall, be sure to inject a contralateral arm if you're imaging an upper extremity. So you don't want to power inject the potentially injured arm. For the lower extremities, since we're going to be scanning it anyway, I have the tech send over images of both extremities for comparison. You can use bolus tracking or a fixed delay. We use a fixed delay just to make it easier and quicker to do. For an isolated upper extremity, 20-second delay tends to work well. A lower extremity, CTA, 25 seconds tends to work really well. But what we do for a whole body CT is we start at the circle of Willis, do the CTA all the way to the feet with a 12-second scan delay, and we've optimized our table pitch so that all the entire z-axis length is a really nice arterial phase. So when people ask me, how should I do an extremity CTA for trauma? I say, do whatever your techs do well. So if they do bolus tracking well, do that. If you're comfortable with a fixed delay and you have experience with that, then do that as well. So let's talk about the different types of vascular injuries. So let's talk about the imaging findings of vascular injuries. We can have direct signs of arterial injury where you can see where the vessel is injured, and you can have indirect signs. The direct signs are vascular occlusion, active bleeding, pseudoaneurysm formation, intimal injury, dissection, and AV fistula. And we'll go through these in a little bit. You can have indirect signs of vascular injury. This is more of an issue in the past when the spatial resolution was not as good as CT scanners are. That includes perivascular hemorrhage. Those patients with increased risk of vascular injury include the vessel within a penetrating wound tract or a projectile within 5 millimeters of a vessel. So let's talk about the different imaging morphologies of peripheral vascular injuries. Occlusion. Occlusion is, without question, the most common imaging feature that you will see in patients with peripheral vascular injuries. In fact, at our institution, over about 70% of patients with vascular injuries of the extremities is occlusion. This can be short segment or long segment, depending on where it's at. You can have abrupt or long tapering. In my experience, though, it's usually abrupt tapering. And this is interesting. The peripheral pulses beyond the vascular injury, they may be absent, they might be diminished, or they might be intact, which is hard to believe, but I see it all the time. So let's take a look at this patient. This is a patient involved in a motorcycle accident with bilateral knee dislocations. The patient had intact distal pulses. The knee dislocations were reduced and CTA was performed. As we can see above the knee, the superficial femoral arteries are patent and intact. Below the knees, three vessel runoff is intact and it's symmetrical. However, as you can see on this 3D volume image, we have segmental occlusion of both popliteal arteries with reconstitution of opacification distally, presumably by the geniculate collaterals. So you cannot use distal opacification to rule out a more proximal injury. If there's one thing that you all take away, let me say it again, you cannot rule out a proximal injury just because you have distal opacification. You will miss vascular injuries if you use that thinking. How about this patient? This is a patient fell from a ladder, bilateral tib-fib fractures. Here's the CTA coronal image showing abrupt cutoff and occlusion of the anterior tibial artery. Very common scenario. Here's another patient following a motorcycle collision with a mid-femoral fracture. Here's the CTA through that region, and notice we include the contralateral side in the field of view. The injured side and the patient's right SFA is intact. On the left, at the level of the fracture, we see a large hematoma, bone fracture fragments, and no vessel. And on 3D image, it's just easier to see what's going on here. We have segmental occlusion of the superficial femoral artery at the level of the fracture. Here's another patient who had a mixed mechanism. They're in an all-terrain vehicle accident with a groin laceration from the handle. So this was a mixed mechanism. And we can see a segmental occlusion of the iliac artery here. The common femoral artery at the level of the inguinal ligament with reconstitution distally. Again, very, very common imaging appearance. Here's a patient with a gunshot wound to the knee region with absent distal pulses. So proximally, we can see the superficial femoral artery is patent. At the level of the popliteal region, there's a glob of contrast that does not look like a vessel. And beyond that point, we see intact distal runoff. On 3D image, we see popliteal artery transection, active bleeding or pseudoaneurysm. It's kind of hard to tell in this instance, segmental occlusion, and then distal opacification. So you can have present or absent distal pulses even with distal opacification. So keep that in mind. Here's a patient with a gunshot wound to the left upper extremity. And here's the scout image. We can see some bullet fragments in the left arm. And as you can see, the patient is generous in size. They're not going to want to move the arm because it's injured and it's painful to move. So we thought, this scan might not turn out well because of patient's body habits. But we tried anyway. And in fact, the images actually turned out quite well. Above the injury, we see intact brachial artery. In the middle image, we see the wound tract with the bullet in the muscles. But where's the vessel? It's gone. It's not opacified. And then beyond that point, we do see distal opacification. So again, you cannot rule out a proximal injury if you have intact distal opacification. So the patient went to angiography, which confirms the occlusion of the brachial artery. They were able to pass a guide wire across the injury distally and repair this with a stent. Let's talk about active bleeding. We see this pretty commonly. So active bleeding is an uncontained leak of contrast opacified blood outside of a vessel. It's usually ill-defined. It's also called a contrast blush. And you can see sometimes a diffusion and dilution of the contrast opacified blood as it extends into the surrounding soft tissues. Differentiating active bleeding from pseudoaneurysm can be difficult, though pseudoaneurysms tend to be more well-defined, which we'll talk about later, and active bleeding tends to be very irregular in shape. Usually patients with active bleeding will require some type of intervention unless it's a superficial muscular branch. So I like to show this case to medical students. I show them a frontal view of the knee in this patient who fell. They have absent distal pulses. And the students, they look at this, they're like, well, it doesn't look quite right. It looks like there's some overlap of the femur and tibia. Then, of course, I show them the lateral, confirming the diagnosis of a knee dislocation. So whenever you see knee dislocation, you have to think popliteal artery injury until proven otherwise. So the knee was reduced. Patient went to CTA. Above the dislocation, the SFA is intact. At the level of the popliteal region, there's active bleeding into the popliteal space with no normal vessel. And below the knee, there is no vascular opacification. So here we have transection of the popliteal artery and active bleeding. Now, why would we get a CTA in this instance? The docs, they knew that there was a vascular injury. And the response is, well, we need to know where to cut. IR and stenting in this region is usually not successful because it's a highly mobile joint. So they know they need to do surgery. They just need to know where to cut. How about this one? Young male stab wound with continued bleeding from the wound. They couldn't help themselves. They had to look. So we did a CTA, and you can see a really irregularly shaped contrast collection at the level of the vascular injury. Now, could this be a complex pseudoaneurysm? Sure, I suppose, but the patient was still hemorrhaging, so we call this active bleeding. Also notice there is short segment occlusion with distal opacification. Here's a patient with a gunshot wound to the thigh region with continued active bleeding from the wound. Again, that's a hard clinical sign of a vascular injury, meaning that there's most likely a vascular injury that's going to require intervention, but they had to look. They had to look to see what they were getting into. As you can see, there's a large collection of contrast in the anterior compartment compatible with active bleeding. Below that point, there's no vessel, and actually you can see some myositis and muscle edema in the penetrating wound tract. And here's a coronal MIP image nicely showing the vascular injury with active bleeding and multiple bullet fragments. So here's active bleeding, extensive soft tissue injury, and distal non-perfusion. Let's talk about pseudoaneurysms. So pseudoaneurysm is a transmural injury to the artery resulting in contained rupture of the vessel. So we have contrast opacified blood extending beyond the vessel wall, but it's not actively bleeding and expanding. These are usually well-defined, usually rounded or oval in shape, and on a single phase, they sometimes can be difficult to differentiate from active bleeding. These usually present acutely because we image these patients we always image these patients. So it's common that we identify these early in the course. And of course, these are biomechanically unstable injuries with increased risk of rupture. So these need some type of intervention. So let's look at some cases. Here's the patient with a stab wound to the left calf. Again, here's the normal side with intact 3-vessel runoff. But on the left side, we see this well-defined lobular contrast opacified structure right here. This is a pseudoaneurysm. The patient went on to angiography and was successfully treated with coil embolization. Here's another patient with a gunshot wound to the popliteal region with decreased distal pulses. We see a lobular, well-defined contrast opacified structure coming from the popliteal artery. This is a pseudoaneurysm. Now again, notice the patient had decreased distal pulses, but there is no interruption of opacification along the vasculature. Now here's a patient who was not imaged initially. This is a patient seen at one of our community hospitals. They were stabbed in the arm 2 days prior. The wound was closed with skin staples, as you can see on the images, and the patient returned 2 days later with bleeding from their wound. So we did a CTA, and we can see a large pseudoaneurysm arising from the brachial artery, which you can see here. And I believe this was treated with endovascular therapy, but I don't have any images. So you can see this in a delayed fashion, but it's not as common nowadays because of ubiquitous use of CTA. Let's talk about intimal injuries. These are not common. I've only seen a handful of intimal injuries in the peripheral vasculature. This is an injury to the intima, which, as you remember from medical school, exposes the underlying media, which is a thrombogenic surface. So you can see lots of things with intimal injuries. You can see an intimal flap. You can see a contour irregularity due to mural thrombus. You can have luminal irregularity, and of course, intraluminal thrombus. So here's a patient that we had a severe multi-system trauma. They had an open wound to the lower extremity, but no fractures. And this patient has a small intimal injury with a small amount of thrombus along the vessel. If this were a 90-year-old, we would still call this a vascular injury because this is such an unusual location for isolated non-calcified plaques. So this is a vascular injury due to an intimal injury. This is an interesting case of a patient with a thigh gunshot wound, and we can see small intimal thrombi in the superficial femoral artery. So you may be asking yourself, wait a second, how can you have a gunshot wound that only injures the intima, but not the media and adventitia? You would expect if this vessel was injured from a bullet that there would be at least active bleeding or a pseudoaneurysm. And what we think happened with this patient is because of the soft tissue cavitation and the so-called shockwave effect as the bullet passed adjacent to the vessel, that caused small intimal tears of the vessel without the bullet actually touching the vessel. So you can occasionally see this. It's not as common in the civilian population because civilian style weapons tend to be lower energy, but don't let this talk you out of calling this a vascular injury. All right, let's talk about traumatic arteriovenous fistulas. And I want to talk about these because they look really weird. Fortunately, they almost always look exactly the same. So let's look at a couple examples. So as you know, an AV fistula is a direct communication between adjacent artery and vein, both of which are injured. Often, especially with large vessels, you can see the fistulous tract connecting these two vessels. In smaller vessels, it's a little harder to see. But in the proximal arm and proximal legs, you can often see the connection. And what are we looking for? Well, we're looking for early venous filling and what I like to call, quote unquote, arterialization of the vein, where you have arterial density within the vein as acquired on CT angiogram. So if you have a really pure arterial phase image acquisition, you shouldn't have venous opacification. But if you do, and it's very similar density to the within the vein compared to the artery, you have to think that there's a short circuit in the system somewhere. Let's take, for instance, this patient with a thigh gunshot wound. We do a CTA. Proximally, the vessels look okay. Along the wound track, however, we see globs of contrast that don't look like normal vessels. So what's going on here? Well, if we go back, we can see the superficial femoral and deep femoral arteries, which are well opacified. But what's this opacified right next to it? It's the common femoral vein. But this is a CTA. You should not have this much venous opacification, especially similar density to the adjacent arteries. So get out your volume viewer and manipulate the images to make a very pretty image. And what we can see is we have two traumatic arteriovenous fistulas between the superficial and deep systems. These have pseudoaneurysms. You can see direct communication. Then you have early venous filling. Now notice there's no venous filling distal to that point. If you had venous filling distal to that point, then it's kind of hard to call an AV fistula. But if you have more proximal venous filling, then you know that you have a short circuit in the system, and the venous opacification is not from normal circulation. So a very unusual case, but they all look just like this. So memorize this appearance. So there's the artery, there's the vein. You should never have that. Here's another patient, stab wound to the left inner thigh. There's the subcutaneous contusion at the surface wound. We see the superficial femoral arteries on the normal side, but on the injured side, what's that extra glob of contrast? So look at your coronal and sagittal MIP images. We can see a fistulous connection between the SFA and adjacent vein with early venous filling. And here's the DSA that looks just like the CTA image. And again, there's the fistulous connection. So AV fistula diagnosed on CTA. So let's wrap up with imaging pitfalls. So there are lots of imaging pitfalls that we can see with peripheral CTA. You can have potentially poor arterial opacification for a number of reasons: patient status, hemodynamic status, poor cardiac output, or your protocol is not optimized. But usually what we see is issues with artifacts or motion. Artifact, especially bullet fragments here in the US. And I'm not sure where it's like where you're at, but we've seen increase in interpersonal violence over the past several years. I was working this night. We had 9 patients show up, essentially a mass casualty situation. The 9 patients showed up at the same time from 3 separate shootings. So let's talk about this. Let's talk about bullet fragments. So consider this patient. A shotgun wound to the knee. There are hundreds of bullet fragments here. Obviously, the distal femur and proximal tibia are fractured. There are pellets in the region of the popliteal artery, so increased risk for vascular injury. Then the surgeons come and say, hey, we want to do a CTA on this patient. Well, you know right away the likelihood that a CTA is going to be diagnostic is low, and that's what you tell them. And then they say, yeah, but the patient's going to go to the OR anyway. We just like to take a look. So there you go. There's the CTA. You can't see anything. Who knows if there's a vascular injury? Now we can see there is distal opacification, but as you know, you cannot use the presence of distal opacification to rule out an injury. So what do we do in this situation? We know that bullet fragments can cause beam hardening and photon starvation, which can obscure a vessel. And if you can't see the vessel, then you can't evaluate it and you can't rule in or rule out a vascular injury. So the general rule of thumb is consider DSA if you have a bullet fragment that's less than 5 millimeters adjacent to the vessel, or you can't see the vessel due to artifact. So keep open communication with your trauma team. If you think there's high likelihood that you're not going to get a diagnostic exam, maybe you should go directly to DSA. Let's look at a few cases. Here's a patient with a gunshot wound to the left shoulder, lots of metal artifact, definite fracture, probably a glenohumeral dislocation here. We thought, this is a high likelihood for vascular injury. It's a challenging location for surgery. Let's try CTA to see if we can see anything. And this is what we get. We see opacification proximally, opacification distally, but of course, that doesn't exclude an injury. And right where the bullet fragments are, we've obscured the vessel. So this is an instance where we said we can't evaluate the vessel, go on to DSA, which is what happened. And there were, in fact, multiple vascular injuries that were obscured by metal artifact. As you can see here, these were injuries to the axillary artery and then one of the circumflex humeral arteries. Here's an interesting patient who was shot in the right arm. As you can see, lots of bullet fragments in the right arm. But if you look very carefully, there are tiny bullet fragments all over the chest and abdomen. And on physical exam, the patient had puncture wounds over the body. So because the patient didn't want to move the arm, we did a whole body CT protocol through the chest, abdomen, and pelvis. We included the arm in the field of view. And because it was a whole body CT, we also included a delayed phase through the abdomen and pelvis, which is standard of care for torso trauma. So here's what we saw. Lots of metal artifact, lots of bone fragments, lots of gas. This was a hard one to read. If we look proximally, we see an intact vessel, intact brachial artery. Distally, we see radial and ulnar arteries, which are opacified but not well. And at the level of the bullet fragments, we just don't see the vessels very well at all. Fortunately, since the arm was in the field of view for the delayed phase, we got a second look at the patient's arm, and we can now see there's active bleeding somewhere in the region of the wound tract. So the patient went to the OR, and the patient had a brachial artery injury, which was surgically repaired. Here's another patient with a thigh gunshot wound. We can see a fractured femur, lots of bullet fragments. We did a CTA, and there's some artifact there, but you can still see the vessel. Here's some coronal MIP images. The artifact gets close to the vessel, but we can see that the vessel is uninjured. The patient's femur fracture was fixed, and they did well. How about this patient, though? The bullet is a little bit closer to the vessel. Let's look closely. We start to see some attenuation of the vessel due to beam hardening. So what do? Well, at our institution, we have on our scanner metal artifact reduction algorithms. So what I had the tech do was take the same raw data, apply the metal artifact reduction algorithm, and reconstruct all the images. And this is what we got. So significantly reduced beam hardening. We can now see the vessel much easier, and we excluded a vascular injury, and the patient did well. But how about this patient? Gunshot wound to the right knee, a really large, really dense bullet fragment with tons of artifact, which obscures the adjacent popliteal artery. There it is there. We just can't see it very well. So I asked the text to reconstruct the images using the metal artifact reduction algorithm. We can now see the vessel, and the popliteal artery is uninjured. However, because of the very scary appearing initial scan, the surgeons asked for DSA, which confirmed that the popliteal artery was in fact uninjured. So what about upper extremity peripheral vascular injuries following gunshot wounds? This is a large study done at the Boston University group. They had 59 patients with penetrating arm trauma. Some of them had lots of artifact. They found no clinically relevant missed injuries, no adverse patient outcomes, and they were able to diagnose and exclude vascular injuries even on some of the more severe cases that you can see here. So the question is, should you do extremity CTA following gunshot wounds? And the answer is, well, it depends. If you're going to do CTA, you have to be prepared to use some advanced imaging techniques such as metal artifact reduction, or go on to catheter angiography for problem solving, or have the surgeons take the patient to surgery. So you have to keep open communication with your techs and your surgeons. So in conclusion, CTA is a very powerful tool that can be used to quickly and accurately diagnose peripheral arterial injuries in the setting of blunt and penetrating trauma. CTA is quick, it's easy to do, and it can provide definitive therapy for peripheral vascular injuries, and it can be used for problem solving, and you have to be ready to use advanced techniques for problem solving, especially in the setting of gunshot wounds. Here are my references that I'd be glad to email to you if you'd like. Before we end up, Indianapolis is known probably the best as the land of fast racing cars. So I wanted to show this to show you how big the Indianapolis Motor Speedway really is. It's a 2.5-mile track, and overlaid to scale are several well-known other large landmarks from around the world. And as you can see, we can fit all these things in the infield of the Indianapolis Motor Speedway. That's all I have for today. Thank you very much for your attention. And I will now turn it back to Ryan at MRI Online.
Well, thank you, Dr. Steenburg. It does look like we have a few questions in the Q&A function.
Okay.
Should you be able to bring those up?
Okay. All right, upper limb blunt trauma, 4-part shoulder fracture, dislocation, no, large, non. All right, so we have a question here about upper limb trauma. You have a 4-part shoulder fracture dislocation, no hard signs preoperative, large non-expanding hematoma only, no pre-op vascular studies, neuroattack pre-op. Patient status post-op, reverse shoulder replacement, has a cold, white, pulseless hand when the drapes come off. Poplar shows pulse at axillary artery. Would you advocate CTA and stent versus open exploration? That's going to come down to, in my experience, that's going to come down to what your local practice environment is. If this patient were still in the OR, our surgeons would do would call in IR, the hybrid suite, and they would do an angiogram right there on the OR table. That's typically what I think would be done. If the patient were out of the OR by that time when they discovered the cool limb, probably they would go to CTA just to see exactly what they're dealing with. But I think there's probably a standard answer in the surgery world, but I think a lot of this may come down to timing of when it's found and the experience of the surgeons there and the operating room capabilities. We have another question here. When you have something you think might be artifact from vasospasm, but vessel looks occluded, what do you do in your report? Okay, so spasm is the bane of our existence for CTA, because you're right, spasm can result in what looks like vessel occlusion, but it might not really be an injury. So there are a couple things you can do. If the patient's doing well and they have a perfused limb, you can do repeat CTA after potentially hours to see if the spasm resolves, and if it's still there, then it's presumed injury. I believe there are some intravascular drugs that can be given to relax the smooth muscle. So that's another problem-solving technique would be with angiography. All right. Next question. How accurate do you think CTA is in evaluating the palmar arch in gunshot wound or firework injury? Okay, so this is tough. You have to really optimize your CTA technique, preferably with your arm above the head to reduce artifact from the adjacent body. And you have to really narrow in the matrix so as to increase spatial resolution at that level. In my experience, those small vessel, evaluating those small vessels is very challenging. So, get your best tech with arm perfectly positioned and a perfectly timed CTA, and you might be able to tell something. But I think a lot of these, especially the fingers and toes, a lot of that might come down to physical exam findings and patient status. Okay, we have a question about power injectors. Okay, so in our department, we use fixed delay for CTA, though you can use bolus tracking or test bolus. What I would suggest is whatever your techs do the best, do that. There's no point in trying to do a CTA a special way that's different than what your techs typically do. So whatever you do best at your institution, do that. At our institution, we just have fixed delay to make things go quicker. Okay, we have a question about radionuclide scanning versus CTA for traumatic GI bleeding. So we rarely at our institution do radionuclide tag red cell scans for GI bleeds anymore. We do a 3-phase CT, non-contrast, followed by arterial phase, and then a 2-minute venous phase, and that's essentially replaced and eliminated red cell scans at our institution. Do you ever use vasodilators during repeat CTA to rule out vasospasm? That's a great question. I've never done it. I think potentially that could potentially be done. I think calcium channel blockers, don't quote me on that, can reduce vasospasm, but that is outside my area of expertise and experience. All right, differentiating pseudoaneurysm from AV fistula in trauma setting. Okay, so differentiating these two require you to have a really good pure arterial phase. If you have a pseudoaneurysm, it's usually lobular, rounded, and well-defined, but no venous enhancement, that's reliable in excluding AV fistula. However, if you see that venous filling right next to the artery, that's an AV fistula. So it's helpful to have a really high quality CTA. If you have a soft tissue phase or a venous phase, then that's going to be really hard to call. Okay, how to differentiate vascular spasm, vascular injury. Yeah, so going back to the whole spasm issue, that's really challenging, especially these small vessels. So you can do a follow-up scan hours or maybe hours later to see if it goes away. What would be the cause for enhancement of segmental vein in angiographic studies without visualization of communication? So this question is getting at what if you don't see the fistulous connection? That's okay. If you see an early draining vein, but you don't see the fistulous connection, it's probably because it's obscured because of the positioning of your C-arm. Okay, is that it? No open questions.
Yeah, I think
Great,
that is it.
fantastic.
All right.
So thank you everyone for coming. Here's my email if you have any questions. Ryan, I'll turn it back to you.
All right. Well, as we bring this to a close, I want to thank Dr. Steenburg for this lecture. And thanks to all of you for participating in our noon conference. A reminder that this conference is available on demand on mrionline.com in addition to all previous noon conferences. Be sure to join us again tomorrow for a lecture from Dr. Anjali Agrawal on Do Not Miss Diagnoses in Emergency Radiology. You can register for that at mrionline.com or follow us on social media at the MRI Online for updates and reminders on upcoming noon conferences. Thanks again, and everyone have a great day.